discussing CTs. و يلا يا منى شوفي الفيلم اللي عائشة حطاه لنا دي اللي كان آخر مرة، بس أنا مش عارف عندي. يلا
منى، هو دلوقتي هتعملي annotation يعني في اللي هو القلم ده تقدري تشاوري.
اوكي كده باين حاجة؟
لا
هو أنا دوست annotation وماوس ولا إيه؟
في زي ما عائشة بتقولك في كده قلم على الجنب هنا صغير بتاع حوالينه دايرة كده.
لا، اختاري مثلا درو عشان هيبقى قلم كده وتقدري تشاوري تعملي تعلمي على حاجة يعني.
ماشي.
تغيري اللون
مثلا كده باين حاجة؟
أيوة تمام.
ماشي.
أيوه بالظبط.
وأي حد يقدر يعني يانوتيت برضو، حتى لو فاتح من على موبايل هيبقى على الجنب على الشمال كده تحت.
تمام.
يلا قولي لنا بقى شوفي الأورطة كده إيه اللي حواليها المرة دي.
الأورطة دي الأورطة
فين الأورطة؟
دي حاجة حواليها اهي.
أوكي أدي الأورطة وأدي اللي حواليها بالظبط. يلا describe it يعني again introduce your CT image. Introduce just tell something about which
Okay,
cuts
this
and
is CT abdomen axial cuts و IV contrast و oral contrast.
okay.
هاي ممكن يبقى ايه مش عارفة.
لا فكري بس يعني describe them. You don't want to diagnose at the beginning. You want to describe them, and then when you describe them, the diagnosis will be very clear. The problem is that you want to know what's going to happen to you throughout your life when you cannot know that at all. Only one knows this thing. You cannot know it. But if you take steps, it keeps appearing. Your pathway keeps appearing. Otherwise, you cannot see your pathway. You have to take the first step. The first step here is just describe. Yalla, what is happening? What is the density? What is the
hyperdense lesion surrounding the aorta?
Hyperdense? Are they really hyperdense? At least compared to the aorta, what are they? At least compared
to the aorta, they're hypodense.
They're hypodense, okay. Type, they're hypodense lesions. Are they homogeneous or heterogeneous?
Heterogeneous.
They're heterogeneous, maybe. Okay, and where are they? Are they in front of the aorta, behind the aorta, beside the aorta?
In some cuts beside the aorta, and in some cuts surrounding the aorta.
They're surrounding the aorta. Can you count them? What is their shape and what is their outline?
Lobulated.
يبقى السيرفس بتاعهم هو في lobules, yes. In one cut, at least the one that is just to the right of the one that you're pointing to, they appear to be. Are they multiple or are they single? In some cuts they're multiple. You can count them at least. So if you 1, 2, 3, 4, 5, 6, 7, 8, something of the sort. What do you think they can be? Are they retro or intraperitoneal?
Retroperitoneal.
Retroperitoneal type. Multiple hypodense lesions surrounding the aorta are probably. What is the most probable diagnosis? بس كده. Excellent enough. This is how you reach a diagnosis. You don't. At times you know the diagnosis offhand. At times it happens, but because this is not the rule, because whatever your rank and whatever your skill in interpreting images, you'll not be able to diagnose things instantaneously in 100% of situations, we need to have a method. The method allows you to reach a diagnosis, at least put the differentials in all circumstances. It will never fail you. You will not reach the proper diagnosis, yes, but you provide a DD at least. What I mean to you first describe them. How do they look? What is their shape? What about their density? What about their homogeneity? What about their location? Maybe before their density and so on, their location. What is their size? These are not cysts. They may be a bit heterogeneous, yes. Yani, what are the two structures that appear on the edges of the, and they're opacifying on the edges of the lesion? The two lesions, two circular small lesions that appear. This one and that, yes, absolutely. Can you put a differential diagnosis for these structures?
مش عارفة، ممكن arteries يعني.
ممكن arteries. حاجة تانية طيب؟ هما شكلهم bilateral symmetrical كده. project them downward شوفي هما ماشيين على أنهي level. if you project them downward شوفي ولا مش باين هنا يمكن قوي. يلا any other suggestions of pacifying or bilateral or on the outer side of the thing? Any other suggestions? Just suggest. Think about them. What will opacify? How will you think about this nature of this lesion, of this anatomical structure? Bilateral opacifying.
حاجة bilateral ممكن ureter بس.
بالظبط كده. لا ليه لا ما هو بيقولوا the door least knocked. بيقولوا the door least knocked. And you keep knocking, you're trying to find someone, you keep knocking, leave knocking, but one door you miss, and it is this door that you miss that is the door that you're after. The door least knocked. The door least knocked. The door least knocked. You keep knocking. You think you've done all your search when you have not, because you've missed on one, and it may be this one that you're missing, that you're really after, or you have not knocked enough. Okay, but they're the ureters. I would suggest they're the ureters. I think so. They're the ureters, but I may be mistaken. طبعا انا دايما بحط الاحتمال ان انا ابقى mistaken. ما عنديش مشكله في كده. ما عنديش مشكله خالص. عندي مشكله بالليل زي ما بقول، لكن يعني at least I pretend I haven't got a problem, which is fair enough, and I don't counteract people who are better than me. I envy them at times. I'm angry at times, بس اقول خلاص هم اشطر مني هعمل لهم ايه يعني. Okay, what about the cava? Can you see the cava? The trick is look at other images. The trick is you should always look at other images. يا ترى الكيفا موجود ولا مش موجود؟ شوفي في image تانية كده. هو الكيفا ممكن يكون حصل له ايه؟ ممكن يكون if this is a lymphadenopathy ايه؟
compressed. يعني
the cava may well be compressed. The cava may well be compressed. Absolutely. What else? What else can happen to the cava in this situation other than being compressed? ممكن يبقى compressed ايه تاني؟ احتمالات.
Displaced.
Displaced. It may be displaced. Compressed, displaced. They're two different things. It can be displaced. It can be compressed.
Infiltrated لو ده tumor مثلا.
Absolutely infiltrated. ما هو ده. هو انت ايه الدي دي بتاع الليمفادينوباثي دي دلوقتي؟ وايه الدي دي؟ What is the DD? What is the lymph nodes of this lymphadenopathy? This is the lymph node anatomically, but pathologically. دايما anatomy pathology. What is the pathology? What
malignancy.
Malignancy يعني ايه؟
يعني spread
يعني ايه منه؟
spread يعني من tumor.
يعني you think that this may be metastasis from another primary? Yes,
maybe.
Absolutely. What else? What else could it be? A parotic lymphadenopathy. ممكن تبقى ايه تاني؟ Inflammatory. I would be very cautious designating or diagnosing para-aortic lymph nodes as inflammatory, I'd be cautious, possibly, but unlikely. I would be cautious. بس في حاجة قبل. Okay, a testicular tumor, yes. Pradeep is saying it could be a testicular tumor, which you've already said because you're talking about a primary metastasizing into para-aortics. Yes, absolutely. Which means that these are the areas that you should be looking for. But what else? What other than a metastasis? في حاجة مهمة. الليمفوما. Absolutely, a lymphoma. ممكن تبقى lymphoma. هو احنا عندنا is this a lymphoma او حاجات تانية rare بقى. يعني para aortic lymph nodes غالبا دي generalized. طبعا انا ما اعرفش يعني. The first thing that you have to do is to look for the lymph nodes all over the body. ايه تاني في الافلام دي ممكن نبص على ايه؟ في السي تي ده ممكن نبص على ايه تاني غير البارا اورتيك ليمفادينوباثي دي عشان نعرف هي سببها ايه؟ يعني عشان نعرف سببها ايه ممكن ايه تاني اللي يبقى كبير؟
الكيدنيز
الكيدنيز ممكن. لكن انت بتقولي دلوقتي ليمفوما ولا ميتاستاتيك؟ انت you're talking about these things. What will help you to reach whether it's a lymphoma or whether it's look at the spleen. If you've got cuts, you better look at the spleen. What do you expect in the spleen if it's a lymphoma? What do you expect in the spleen?
تبقى enlarged.
تبقى enlarged, yes. يبقى ممكن يكون في splenomegaly, which will take into consideration. If you're a radiologist, you're not a radiologist only. You're a clinician that diagnoses through images. هي نفس الكلام. Clinicians are examine people, but you examine the images. يعني هي مكملة. You haven't got a history. That is why you have to insist that clinicians provide you with a good history, so that you reach your diagnosis. And so you don't just describe things. You want to reach a diagnosis. You want to provide clinicians with further clues to the diagnosis. Okay, طبعا not only to the diagnosis but to the relations. الجراح برضو بيستفيد قوي. Surgeons benefit a lot from images because they can plan their approaches and they can anticipate where to find important structures and so on. So it's also about the relations. It's not only about the diagnosis, but it's also about the relations. طبعا بقى غير السي تي جادد بايوبسي والحاجات اللي انتوا اكيد عارفينها دي. ده بيبقى you're looking at the spleen. Yes, ممكن يبقى في spleen تاني غير انه يبقى enlarged, diffusely enlarged. We've already seen this thing. What could there be in the spleen other than it being diffusely enlarged?
multiple heterogeneous lesions.
بالظبط. ايات بتقول كده. دي ايات مش كده.
ايات يا دكتور.
ايات بتقول ممكن يكون في multiple heterogeneous lesions. ودلوقتي مين اللي بيعلم بالقلم البيربل او الفوشيا ده؟
انا.
انت يا منى. طيب what is this? What do you suggest this is? صح؟ دي ايه؟ بالراحة. You describe it. You cannot see the whole of your life pathway when you're a 60-year medical student. You cannot ever. But you take one step and then you sit for an exam and then you pass your exam and then you train I don't know where and then you become a consultant and then you want to become I don't know what and then you want to become what, but at the beginning you cannot see all this and new pathways may open. You never know. فيلا قولي لنا بقى دي ايه؟
هي heterogeneous.
heterogeneous. قولي لنا الوانها.
hypodense.
يعني homogeneous ولا heterogeneous؟ heterogeneous. طيب describe the densities. Where are the densities? How many densities are there within this lesion? في كم density يا منى؟
في 3 مثلا.
At least 3. يلا describe them. Where are they located within the lesion? What lies in the middle?
In the middle في hypodense.
Hypodense. Above ولا below?
Above.
Looking like what does this hypodense ايه؟
يعني slit like.
لا بس it looks like which part of which organ would you suggest? Which structure? Is it bone? Is it fluid? Is it air? Is it fat?
air أو fat.
air أو fat.
هو كله.
Choose something. Choose something. Choose something. Air ولا fat?
air.
Air. You choose things through two main mechanisms. You may be told to choose things, but you may choose things on your own, either because you haven't got an idea and it's just a matter of trial and error, or you've got an insight. Your insight may be wrong, and your trial and error may be correct from the very beginning, even if you don't really know. It's either this or that. If you don't know how to get inside the room, for example, you keep trying the different doors, but at times someone tells you, I've been in this hall before, and this is the door that leads to the entrance. Go through this door. And you may not know, and you try the door, and the first door that you try opens, but it's just good luck. يلا. But this is air. air وتحته ايه؟ air وتحته ايه؟ اللي تحته؟
ده hyperdense.
Hyperdense. Looking like, what is this hyperdense? صح, that you've marked, or I don't know what very nice color that you're using. فايه الاريا صح؟ الاريا دي ايه دي تفتكري؟ Its density. Do you think you can rate this density? Have you got a reference point? So this density, you think, is something that you already know from the image?
Maybe contrast.
Maybe contrast. يبقى هنا في ايه؟ يبقى between the air and the contrast, what is the interface? How does the interface look like between the air and the contrast?
density يعني؟
لا, the interface. The junctional area between the air and the contrast.
يعني كأنه fluid level.
ايوه بالظبط كده, كأنه air fluid level. بس هو air contrast level, مش مشكلة, ما هو air fluid برضه, air fluid level. يبقى what do you think this is؟
يبقى ده باول.
يبقى باول, والرول بتاعته مالها؟ الرول بتاعته مالها؟
hypertrophy.
بالظبط كده. يبقى any suggestions that this man has got a very thickened wall of which part of the colon?
يبقى cancer, ممكن يبقى colon cancer.
تمام. any part of the colon دي? any part of the colon?
ascending.
تمام. maybe the ascending. Yes, I agree totally. I'm not at all concerned about this. It may be the ascending colon. تمام. If it close to the liver, it would have been. If you're very close to the liver, what could it have been? If you're close to the liver, حتى بصي تلاقي انزلي لتحت كده تشوفي افلام برضو more and more. يلا انزلي اتحركي towards your right hand side. شايفه الفيلم اللي عندك هنا ده؟ شايفه الكولون هنا عامل ازاي برضو؟ شايفاه؟
ممكن بقى يبقى الفلكشر وداخل على الترانسفيرس.
احنا هنا I think we are at a lower level. هو طالع فوق نازل تحت, يبقى it's the right colon. يبقى يلا diagnosis. قولنا what is the image that we've seen and what have we diagnosed?
This is CT abdomen axial cut with IV and oral contrast with
على طول contrast
hypodense
abdominal CT. على طول contrast enhanced بين قوسين oral / IV axial CT, abdominal axial CT. Yes, and what does it show?
It shows multiple hypodense lesions surrounding the aorta.
Yes.
Most probably lymph nodes.
أو خلاص no longer has a time limit. خلاص. يبقى الزوم ميتنج ده ملوش تايم ليميت الحمد لله زي ما كنا متوقعين. we've got بقى our time. We'll be finishing around مش عايشة انت موجودة معانا لغاية امتى؟
لغاية 9 إن شاء الله.
خلاص كويس قوي. يبقى احنا يعني ميعادك 9 ولا ميعادك كام في الشغل؟
لا ممكن نخلص 9 مش مشكلة.
يعني نخلص 9 خلاص. يبقى احنا ميعادنا we may take a 5-minute break in the middle but we'll continue until 9 o'clock. وإن شاء الله if Minna the good is exhausted in the middle, someone will take over. But if she's not exhausted, she'll continue. It's entirely up to her to decide by 8:10 كده to decide whether she'll continue or she wants someone to take over. خلاص يبقى انت قلتي a beautiful diagnosis اهو lymphadenopathy para-aortic and lesion the colon. How would you confirm the diagnosis of the colonic lesion?
biopsy.
Yes, how will you take the biopsy صح؟ How will you take the biopsy?
colonoscopy.
هتعملي colonoscopy تاخدي biopsy, yes. And then what treatment do you plan? What treatment will you plan?
على حسب بقى مش عارفة.
اختاري على حسب. Is a biopsy mandatory? Do you think a biopsy is mandatory?
Yes.
What do you think? يعني طبعا you need to take a biopsy, but it doesn't matter because the disease on the colon and this is the right side. The right side you'll never end up in a colostomy. فمش هتفرق قوي. لكن yes, obviously you'll scope people because people want to know their prognosis and they want to know what's happening with them, whether they receive chemotherapy or not. وطبعا في رول دلوقتي لنيو adjuvant therapy في الكولون في الريكتم بالذات. في الكولون كمان maybe but much less, but in the colon obviously, in the rectum I mean. Okay, and what is suggested treatment?
هشيله بقى.
تشيلي لما تشيل الكولون يبقى اسمه ايه؟
total colectomy.
مش عارف colectomy.
لا مش عارفه الاول because you know if you say you don't know then people get the impression that you don't know when you know. Even if you don't think you know, this is different. As it's different, by the way, you know things that you do not know that you know. يعني it's a colectomy, right ولا left? Right ولا left? بس كده عاوزة اسمعك تقولي right colectomy and it's half the colon يبقى اسمها right ايه؟ half.
right colectomy. hemi colectomy.
right hemicolectomy بس كده. This is what I want you to hear. I want to hear. This is the treatment, is the right hemicolectomy. Even if it's a para-aortic lymphadenopathy, you won't care about the lymph nodes. You remove the tumor because you don't want it to obstruct, and you don't want it to bleed, and you don't want it to perforate. The colon is always resected, irrespective, just like the testis. كنا بنقول التestis, you always remove it, and then you start the treatment, whether it's chemo, whether it's radio, whether it's surveillance, whatever it is, but you initially remove it. It's the same with the colon. You remove it because you don't want it to perforate. You leave it behind, and it perforates, and it obstructs, and then you need to perform a colostomy. You just remove it. Testis نفس الكلام من testis. You don't want it to infiltrate the scrotum. You don't want it to. You want basically you remove it for a histology, and moreover, it's a very easy procedure. But the correct design is more complicated. Okay? يبقى دي para-aortic lymphadenopathy. احنا بنشوف الحاجات. We're concentrating on CT now. We're not talking about a special system. We'll review the systems later on, but at the moment we're talking about CTs. CT as a modality. يلا نشوف اللي بعد كده يا عائشة من فضلك. شفت احنا سكرين. مين اللي عاوز يقول حاجة؟
عبد الله دكتور معاك.
قول يا عبد الله.
ليه we don't proceed to biopsy it. مش محتاجين نعمل biopsy ليه؟
ما ايه يا عبد الله بتقول ايه؟
Why don't we need to biopsy it?
We don't need to biopsy because you remove it anyways. يعني a biopsy, yes, you'll go for a biopsy, but if you miss a biopsy, it's not a major issue. مش زي الريكتم. في الريكتم, if you don't biopsy and you end up with a colostomy, then it's a major issue because you wouldn't provide someone you wouldn't give someone a colostomy unless they are malignant. You have to know the nature. But في the right colon, you remove it anyways. But this is what I meant. A biopsy is you'll take a biopsy. مفيش حد لا طبعا. The biopsy, the colon is one of the tumors that you biopsy as a rule, but it's much more important in the rectum because in other parts of the colon, lesions will be removed irrespective of their nature. But in the rectum, if you remove it and you end up with a colostomy when it was not needed, then and there's no proof انها malignant, تبقى a major problem. بس فده عشان كده كنت بقول الكلام ده. Pradeep, what are you talking about? What did you you're asking about something?
Doctor, I mean, in this case, we will do colostomy, and after that, I mean, we should go for a stoma or reanastomosis. That is very unclear to me.
I mean, this is a big issue, Pradeep, that will not settle at the moment because it's really, it needs a major discussion. But on the right side of the colon, you will be happy to remove the colon and reanastomose it in one go. Just go for that.
We will discuss in GIT, I guess, right?
Yes, we'll discuss it in full detail. But at the moment, you just need to remember that you'll on the right side of the colon, it is perfectly acceptable to remove the colon and reanastomose the ileum to the transverse colon. That is iliotransverse anastomosis or iliotransversostomy or iliotransverse colostomy, as they call it at times. And you don't need any preparation even, whether it's elective, whether it is emergency, you don't need any preparation. Although, if the general condition of the individual is not good, then you need to perform a covering ileostomy, an ileostomy before your anastomosis, or you exteriorize an ileostomy and the distal mucous viscera. It needs a major discussion. It won't be settled that easily. On the left colon, it's different. On the left side of the colon, if someone is obstructed, then you tend to perform a colostomy, a simple colostomy, and then proceed with the resection, then close or restore continuity. Okay.
And doctor, in this case, we also have to do lymphadenectomy retroperitoneally.
Probably not, because if the lymph nodes, the para-aortic lymph nodes are involved, then you cannot go beyond them. So your resection is always palliative. In order for your resection to be a curative one, you need to have removed nodes beyond what is involved. Because you'll not be able to remove nodes beyond the para-aortic, then your resection is almost always a palliative one. If I am conveying the message properly, the lymph node basins, that are affected should be one less affected. The ones removed should be one less affected. If you imagine that there are three sort of rectangles, one inside the other, okay, the one inside is A, the one the bigger one is B, and the biggest one is C. In order for your resection to be curative, you should have removed all three, but C is negative. If C is already positive, then you cannot assume that your resection is curative, because you never know whether you've left behind or not. They don't usually go for a para-aortic lymphadenectomy. Okay.
Okay.
With a colon in particular, يعني.
Okay, تمام.
يلا يا منى. قول لنا what's going on with this situation.
هو يعني الإيمج دي CT.
الايمج دي CT، اعتقد كده انها CT. ولا انت رايك ليك راي مختلف؟
ايوه، انا شايفه انها CT واكزيال كات، بس في بقى
بس في كمان
اسمها ايه، كورونال او
كورونال، وايه كمان؟
ساجيتال
ساجيتال.
في كورونال وفي ساجيتال بالظبط. وفي ايه كمان images at the lower images on your right hand side, what are they?
The lower
يعني هو احنا عندنا كام ايمج؟ هم عندنا بالظبط كده. تمام. يبقى we've got a variety of images. و يلا what is the region that you see? You almost always get to the axial cuts. Your axial cuts are the very very original ones.
في hypodense lesion 5-7 centimeters.
Okay. Where is it? Where is this? Is it heterogeneously? Is it homogeneous or heterogeneous?
Heterogeneous beside the aorta on its left side.
تمام. And what is it doing to the aorta?
Anterior.
displacing it.
Displacing it. In which direction?
To the right, displacing it to the right.
بس to the right ولا كمان
أو
حاجة غير to the right؟
Anterior.
Anteriorly. بالظبط كده. Okay. Do you think the vertebra is normal?
لا affected.
Yeah, the vertebra may not be normal. Yes. It seems to me that the lesion is infiltrating the vertebra, this vertebral body. Yes, it appears to be like that. Okay. Where do you suggest the cava is? Where is the cava? Maybe you can see it on the coronal image. Maybe on the coronal image, it's this one. Yes. Can you see it on the coronal image? Minna, can you see the cava on the coronal image?
مزوق يمين كده.
موجود يا منى اهو. يعني الاورطه. ايوه هو ده بالظبط. This is the cava.
فين الأورطة؟ دي
الاورطه
دي بقية الأورطة.
مستخبي وراها بالظبط.
دي بقيتها.
ايوه بقيه الاورطه في حته فوق فيها صبغه اهي. and going it is probably covered by the lesion. كنت اسالك على ايه يا ربي؟ How about its outline? How about the outline of this lesion?
irregular outline.
Do you think
heterogeneous.
it's infiltrating the psoas? You think it's infiltrating the psoas?
Yes.
The history of this man, he was 35 years old, or he was 40 years old. He had an orchidectomy a few months earlier, and he was already on chemotherapy. He was receiving cisplatin, and he already had the feeling of pins and needles in both lower limbs. And this was his CT a few months after the successful treatment of or successful orchidectomy through the groin.
يبقى lymph nodes.
يبقى lymph nodes. Do you think
abscess?
Was psoas abscess? يعني what do you think about the psoas abscess? ايه رايك يا منى؟
مش سيستك لا.
فمنى رايك ايه؟ مش سيستك؟ مين اللي بيقول مش سيستك؟
انا عبد الرحمن يا دكتور.
عبد الرحمن ازيك؟ فينك من زمان؟ اخبارك ايه؟ كويس؟
الحمد لله بخير يا دكتور.
طيب do you think this is cystic يا منى؟
لا.
You don't think this is cystic? Why don't you think it's cystic? Why don't you think it's cystic?
عشان heterogeneous irregular.
Because of its density. This is not the density of fluid بالضبط to our basic minds. يعني be cautious a bit when you diagnose a cyst or no cyst, but I don't think this is a cyst. We don't think this is abscess. This man had an orchidectomy or an orchiectomy through the groin a few months earlier, and he was on cisplatin, and he was complaining of these pins and needles starting from the tips of the toes all the way up to the knees. فقال لي انت قلتي lymph nodes. lymph nodes من ايه يعني؟ من
التستس.
تستس اللي هو تفتكري كان عنده انهي تيومر فيها؟
سيمينوما probably.
ايه رايك يا منى؟ سيمينوما زي ما حد بيقول، زي ما عبد الرحمن بيقول، على حسب ما افهم، ولا تيراتوما؟ سيمينوما. يعني if this man is 40, then you expect them to have a seminoma rather than a teratoma. If it's already spread to the nodes, it's probably seminomatous rather than teratomatous. Although it can be a teratoma, it could well be a teratoma. يعني ما فيش مشكلة خالص. لكن this was a germ cell tumor, and it was already metastatic to the, or it metastasized later on. What would you do with this mass? هتعملي الماس دي ايه؟ قول لنا لو سمينوها لو تيراتوما. لو سمينوها تعملها ايه؟ والتيراتوما تعملي لها ايه؟
هشيلها.
راديو ريزكشن.
أو
لو سمينوما ممكن تعمل لها ايه؟
راديو ثيرابي.
ايه رايك يا منى؟ السمينوما مع راديو سنسيتيف فممكن be irradiated. If there's a little mass, you may not remove it. While if it's teratoma, you go on removing it probably اللي هي اللي هتبقى retroperitoneal lymph node dissection. Do you think it will be an easy one ولا a difficult one؟
Very difficult.
منى ايه رأيك؟
هتبقى difficult.
هتبقى difficult. تمام. يبقى اهو this was فعلا a man who had an orchiectomy or orchidectomy, and these were metastatic nodes from his testicular neoplasm. He was receiving chemotherapy. And why did he develop? What are the pins and needles in his feet and in both feet? ايه البنز and needles دول يا منى؟
Latin.
هو يعني هنخلي منى تقول، ولو حد عاوز يقول هيقول عاوز اقول، لكن بين احنا مختارين منى ومنى توك ذا انيشيتيف ومين دلوقتي لو حد عاوز يكمل بعد كده بعد الساعه 8 و10 فهيز ويلكم او they're welcome او she's welcome او you're all welcome to share obviously. منى بيعمل ايه السيستاتين والكاربوبلاتين بيعملوا كومبليكيشن ايه؟
بيعملوا مش عارف.
البينز اند نيدلز يعني when someone has got pins and needles حاسس انه بيتشكشك كده في كل حته زي يعني just like when you sit in an uncomfortable position and then you sort of your leg becomes all pins and needles اللي هو الاحساس ده يعني بيبقى what complication neuropathy. Perfect neuropathy قلنا قبل كده that chemotherapeutics in general have got common complications. ايه الكومبليكيشنز بتاعت الكيموثيرابي يا منى؟ بتعمل ايه كل الكيموثيرابيوتكس بيعملوا ايه؟ بيأثروا على انهي سيلز؟ بيأثروا على انهي سيلز؟
كل السيلز.
كل السيلز؟ كل السيلز ولا the more
the regenerating اللي هم
تمام. انهي سيلز بقى اللي في البودي اللي بيريجنريت
البون
بسرعه
مارو.
قوي؟ البون مارو ده طبعا this is the limiting factor.
germ cells.
But other cells
germ
keep
cells.
growing. ايه؟
الgerm
cells. cells صح. ايه كمان؟ How about the scalp? How the scalp pot keeps growing very quickly? The scalp.
الhair.
The hair. The hair. You know, people going to the nuclear medicine or to the oncology department with baseball caps and back caps, wearing caps because they're not very happy with the hair loss. They lose their hair and they do not like it. Obviously, who likes it? يعني okay, hair loss. طبعا hair loss is just a cosmetic problem. It's important, yes, because people become depressed, and if people become depressed, they resist tumors much less. Like it's the bone marrow that kills because of the thrombocytopenia, the leukopenia, and the anemia. لكن ايه تاني غير كده؟ والgerm cells not a very important issue طبعا as regards survival. an important issue long term. ايه كمان؟ ايه كمان انهي cells بتأثر كمان؟ انهي cells بتأثر برضو اللي بتدخل dividing غير الجيرم وغير
epithelium.
الابيثيليوم اللي هو بتاع ايه؟ انهي ابيثيليوم بالذات يعني؟
ممكن GIT.
ايوه GIT. GIT absolutely. The mucosa of the GIT because it keeps regenerating. People nauseated, people with develop diarrhea يعني I cannot see the spleen. Someone's pointing at the spleen. I cannot see the spleen. Maybe it's removed, but I cannot see it. I can see the stomach and I can see the liver, but I cannot see the spleen. يلا نشوف حاجة تانية.
contrast enhanced CT abdomen axial cuts.
Okay.
في هنا region
فين؟ هنا في region
displacing the aorta
بالتالي
وheterogeneous
it looks very similar بالظبط heterogeneous. It's the same. What is it again?
lymph nodes.
lymph nodinopathy بالظبط كده.
lymphadenopathy.
اوكي. عاوزك توري لي الجول بلادر. Where's the gall bladder? وريني الجول بلادر كده. Can you see the gall bladder? We cannot see the gall bladder. تمام. اوكي يلا نشوف اللي بعد. The screen is there in this situation. يلا عايزين نشوف اللي بعد كده. ما فيش حاجة بتتاخد منها يا عائشة، بس مش مهم. لا دونت وري. يلا شوف اللي بعد كده يا عائشة من فضلك. يلا ايه اللي بيحصل هنا؟
هي متشقلبة.
وده نفس الراجل على فكرة. فايه اللي بيحصل له؟ نايم ازاي بس يعني؟
متشقلب يعني
متشقلب بالظبط كده. تفتكري ايه اللي متشقلب؟ وايه في ايه داخل
ممكن
فيه كده؟
في ده يبقى بايوبسي، ياخد بايوبسي.
بالظبط كده. يبقى ده بياخد منه ايه؟
lymph node
زي ما انت
biopsy.
قلتي. يعني CT guided biopsy. I wouldn't have thought it was needed بصراحة. يعني I don't think it was needed, but this is what happened. They were biopsying it. It looks really malignant and really it looks very ugly. لكن خلاص they biopsied it. واستعملنا الصورة just to remind you that you can very well biopsy a lesion guided by CT. فده needle biopsy, yes, it's a needle biopsy obviously. They're prone because you'll not transgress the peritoneum in order to reach these lymph nodes. Otherwise, you may be risking injury to the bowel. But from the back, it's very, very safe. The aorta is pushed to one side, and you're going through the area that is all lymph node tissue. And obviously, you remove it, and you'll send it to pathology. And you may need. طبعا this history in this man is easy. لكن you may need in general, if you're dealing with a lymph node, you may need. And what may you need when you're biopsying a node and you've biopsied and send it to histopathology? ممكن عشان to improve your diagnosis, to improve on your diagnosis. ممكن الباثولوجيست يطلب انه يعمل ايه، او انت تطلبي ايه من الباثولوجيست. Not just a lymph node, an ordinary lymph node. What do you do with the lymph node as well? يعني
بعد ما اخد بايوبسي،
يعني خدتي بايوبسي بعتيها للهيستوباثولوجيست. Okay, and it comes back as a lymphoma, for example. Okay. Would you care for any other tests? Would the pathologist suggest any other tests? Would you request any other tests? على الباثولوجي، على الhistopathology, something that is commonly forgotten. I don't know why. Suppose you find the tumor, you're unable to identify the cell of its origin. What would you do?
Immunohistochemical.
تمام. يبقى عبد الرحمن بيقول immunophenotyping. Then you subject the tumor to a lot of antibodies in order to identify the antigens within the cells, so that you are able to identify its origin. Do not forget immunophenotyping. Immunophenotyping, which is a very important adjunct to the diagnosis, because it makes people sure of the diagnosis rather than just look at the cells and identify them through their appearances. It's a great improvement on the histopathological diagnosis, particularly when the tumor is anaplastic. طبعا lymphomas are all phenotyped. Otherwise, you never know whether which cell type is giving rise to the lymphoma. انت عارفه طبعا في انواع كثيره من الليمفوما، بالذات انهي تايب. الليمفوماز بيتقسموا لايه والايه يا منى؟
هوتشكن ونون هوتشكن.
هوتشكن ونون هوتشكن. طبعا الهوتشكن's disease is one cell type, but non-Hodgkin is a conglomerate group, يعني a variety, a diverse group that needs a lot of phenotyping so that you know which cell, and there are so many trials ongoing to decide on which type of chemotherapy, even so on. طب يلا نكمل. يبقى الليمف نودز خلاص بقى بالتالي هنسيبنا بقى من النودز دول ولا لسه في حاجه كمان هنشوفها؟
دكتور ممكن
ايوه
أسأل سؤال؟ هو
طبعا.
ليه
في نور ولا
النيدل
مين؟
نور دكتور، هي ليه النيدل واصلة لغاية ظهره خالص؟ هي مش الليمف نود قدام شوية؟ ومش كده
هي
داخل
لسه ما
في
دخلتش،
الماسلز اللي هي
هي لسه
السيركمس؟
ما هي داخله في المصل عشان توصل لها، بس هي جايه ثرو ذا ماسل وهي واصله يعني. بس هي
اوكي، جاية من الظهر يعني.
ما هو when Vicious Mena was commenting, she said that this man was prone. This man was prone. يعني you can see the vertebral bodies on the front and not on the back. But this man, paradoxical to all the لأن أنت عارفة إن إحنا we've already standardized the method to position people when they're being axially imaged. They lie on their back. They don't lie on their ventral surface. But this man was already prone in order to لأن اتفقنا إنه if you try to access the nodes anteriorly, obviously it becomes very, very dangerous and difficult. You have to transgress the peritoneum. Why do you want to do that? It's much easier to go from the back or from behind يعني.
يعني دكتور هو بيدخل يعني هو بيبقى عامل اي ايميجنج، هو بيدخل البيوبسي نيدل ولا هو بس بيخش وبعد كده بيصور؟
لا بيبيوبسي، هو بيشوف لان هو لازم يشوف هو داخل فين.
يعني السي تي ده بيتعمل during البروسيجر؟
طبعا وبعدين بياخد static image.
اوكي ثانك يو.
اوكي يلا بعد كده هنوري ايه يا عائشه؟ كنا ورينا فيلم ظريف برضو. يلا يا منى شوف لنا ايه الفيلم ده.
هو برضو يعني سي تي abdomen axial cut وفي contrast oral و IV.
ايوه
في بقى ايه ممكن ده مش عارفه ايه.
لا بس انت انت you just go describing. For God's sake, you just describe. You cannot ask yourself, you cannot request that you know the diagnosis. You have not seen enough CTs to know the diagnosis of everything. You should not be exhausting yourself like that. You should be able to describe, because this you've known to describe. You can describe anything. بالظبط كده. انت معلمه على حاجه كده مليانه اهي. مليانه ايه؟
heterogeneous lesion.
heterogeneous lesion ولا lesions؟ ايه رايك؟ lesions حوالين الاورطه والايه بتاعه. ايه اللي طالع منه ده؟ ايه انهي برانش طالع منه في اول فيلم؟ ايه البرانش اللي طالع منه ده؟
السوبيريور ميزنتريك.
بالظبط كده. مش في ليجنز اهم مليانين اهم everywhere وانفولفينج ذا ميزنتري. وانت شايف الاس ام اي والاس ام في اهم اللي انت بتشاور عليهم دول. دول اجين دول para aortic lymph nodes وميزنتريك nodes. whatever they may be, you should be looking for the intestine. There may be something in the intestine, or it may be again lymphoma of Asia. أنا بقول أهو. What could it else? What could it be else other than a local cause? Other than a local cause,
metastasis.
It could well be metastasis اللي هو local cause. But what other than a local cause? ممكن تبقى other than a local cause. زي ما قلنا what could it be? الجهاز الفيلوباتي may be
الليمفوما.
ممكن تبقى ليمفوما. ما نعرفش دي جهاز ولا localized يعني. para aortic طبعا ممكن يبقوا حاجه localized بقى. You name them, the stomach, the pancreas, the colon. طبعا the colon is CRC, colorectal cancer is the commonest, but it can be pancreatic, can be esophageal, can be gastric, can be whatever it is. لكن it could also be a lymphoma. You can see the nodes on either side of the aorta. You can see the nodes extending into the mesentery. You can see the nodes around the superior mesenteric. Multiple hypodense lesions, where they are all I don't know how many are they. They seem to be discrete. They're pushing. If you go on to the to the image on your extreme right hand side. وريني كده فين الاورطه، فين الاي في سي، وفين فين الباول، وفين الميزنتريك فيسلز.
دي الاورطه.
لا الافلام اللي بعد كده كمان. ايوه ايوه دي الاورطه اهي. فين الاي في سي؟
دي
where do you think the
الاورطه.
IVC is؟
ده هنا.
فين؟ خليكي في نفس الصوره اللي احنا بنشوفها اللي فوق. ايه
اللي
نفس
فوق.
الصوره اللي فوق اللي انت معلمه عليها في اهو، ده الاي في سي صح؟ طيب وفين الميزنتريك فيسلز؟
هنا.
فين الميزنتريك فيسلز؟ الصوره انت معلمه عليها دي اللي فوقها يعني يا منى، الصوره اللي انت بتبتدي تعلمي عليها في الاورطه اهو الميزنتريك فيسلز. وايه الستراكشر اللي وراهم ده على طول؟ في ستراكشر لونه that looks something like gray and it's the space of the aorta, the one that is ايوه ده ايه ده تفتكري؟
بنكرياس.
تفتكري ممكن ايه يبقى غير البنكرياس؟ امشي معاه كده شوفي is it pacifying by any means؟ شوفي امشي معاه كده towards your right hand side و towards look at the image that is just before بالظبط كده. يلا في اي مقترح تاني غير انه البنكرياس؟
duodenum في contrast.
يبقى this is the duodenum, the third part of the duodenum. We can see how it is already pushed anteriorly by retroperitoneal nodes. You can see that there are nodes between it and the aorta. Oh, شايفة the nodes that lie behind it, the gray area. But this is طبعا probably a lymphoma. What would I mean strengthen the diagnosis of a lymphoma؟ في كلمة strengthen بس أنا مش عارفها دلوقتي. ايه اللي هيدعم تشخيص الليمفوما هنا؟ What would you like to look for?
The spleen.
The spleen would like to look for the spleen whether it's enlarged or not. طبعا ايه and whether obviously if they're hypo I don't know يعني hypodense focal lesions in the spleen, it would almost clinch the diagnosis, although you still need a biopsy because you won't start giving them chemotherapy unless you know the type of lymphoma. اوكي يلا ممكن
فين السبلين هنا؟
ما فيش سبين هنا. الفيلم ده ما شفناش فيه سبين. يمكن لو شفنا لان الافلام دي واطيه، فلو كنا شفنا افلام اعلى يمكن كنا نشوف فيها سبين. but there is no spin in these films. Okay, if we go a bit higher the spin may be there, but in these images I cannot see it. اتكلم على كلام نظري بس. يلا نشوف اللي بعد كده يا عائشه من فضلك.
دكتور
دكتور
هو دلوقتي اللي فوق دوت الليفر صح؟
اللي فوق ده الليفر.
طب دكتور هو احنا ليه قلنا ان الباول فيه كونتراست؟ انا حاسه ان الباول لونه اسود عادي مش لونه كونتراست.
لا ازاي؟ لا ليه؟ نرجع تاني يا عائشه من فضلك. في حته باول اهي ناحيه الليفر اهو، ناحيه الليفر في حته باول واضحه وفي حته باول تحت اهي. ليه يا نور بتقولي ما فيش اهو؟ there are a lot of them. You can see that part of the bowel that is very close to the liver where it's hepatic flexure. You can see it, and you can see part of the bowel that is the duodenum اهو containing bowel to your right hand side بالظبط اللي منها بتشرح. Oh, there are loads of areas of the bowel that contain contrast.
اوكي يعني هما دول بس، انما كل الاسود ده مش باول يعني؟
لا كل اسود ده مش باول، كل اسود دول lymph nodes، كل دول lymph nodes.
يعني even دول مثلا
مش متاكد اللي تحت خالص، مش متاكد دول، مش متاكد.
دول
probably these are bowel loops. probably they are bowel loops. ايه في mesenteric vessels in between كده. I think that these are bowel loops and they're not the same density as the lymph nodes. I think these are bowel loops.
Yes. طب هما ليه ما فيهمش contrast؟
Because you can never fill the bowel loops homogeneously with contrast. You can never do that. They just fill with contrast, do not fill according to their rate of gastric evacuation and according to the peristalsis. If you want to ensure better contrast filling, then you have to pass a tube inside the duodenum. so that you control the degree of filling of the bowel loops. But it's cumbersome to pass, and it's not the standard. Okay, فاحنا بنعتمد على you just give people oral contrast and they swallow it and they ingest it. I mean, and it takes time until it gets inside their bowel loops, and it's never homogeneous. And if you want to fill the rectum, you go on for a rectal بالضبط contrast. And the contrast is not barium. It's not barium because barium is too dense for the usually too dense for the CT. The CT, because of extreme sensitivity, you don't usually use barium. You use gastrographin. Okay. يلا لا مش اي حاجه. يبقى احنا شفنا منى، تعرفي تقول لنا احنا شفنا ايه في السيتيز؟
في كل اللي شفناه يعني شفنا
في السيتيز غير الاناتومي طبعا. شفنا ايه في السيتيز الابدومين سيتيز؟ لما شفنا السبين، شفنا ايه في السبين؟
شفنا رابتشر
رابتشر سبين صح؟
وسبلينوميجالي.
سبلينوميجالي دي في سبلينوميجالي يس. وايه كمان سبين مليان ايه؟
وسيست او
سوليتري سبينك سيست. وسبين مليان ايه؟ مليان يعني في مالتيبل ايه؟ مالتيبل ايه؟ ليمفوما هو فوكال سانج ديفكتس. شفنا سبين مليان مالتيبل سيستس يس. وشفنا اسبانيك. If you find this an air fluid level inside the spine, it is probably
cyst.
An air fluid level, a cyst with an air fluid level, it's probably become an what does it become?
Abscess أو
aspirated
cyst.
بالظبط. يبقى we've seen a simple cyst, cyst with an air fluid level, multiple focal lesions of the spine, probably a lymphoma, ruptured spine, splenomegaly, mosaic appearance of the spine. And then we've gone on to identify or review vascular lesions. ايه الفاسكولار lesions شفناها؟
شفنا aneurysm.
شفنا
rupture aneurysm أو leaking
aneurysm. وايه؟
leaking يعني.
اوكي leaking aneurysm. وايه كمان؟ صح. وايه كمان؟
وشفنا
الانيوريزم اللي حصل فيه complication ثانيه. what other complication can develop؟
كان في
thrombosed aneurysm بالظبط كده. شفنا another type of vascular pathology in the artery. what did we see in the artery as well؟ شفنا ايه في الارتري كمان؟ الارتري ممكن يحصل له ايه تاني؟ بيجي بتشست بين او abdominal pain refer to the back. dissection. شفنا dissection. شفنا ايه كمان في الكيفا؟ المره اللي فاتت ده انت اللي شفتيها. في الكيفا. كانت ايه في الكيفا؟ ثرومبوزس. كيفا ثرومبوزس. شفنا ايه النهارده شفنا ايه كمان؟
النهارده شفنا lymph nodes para-aortic
خدنا منها ايه كمان؟ خدنا منها ايه؟
بايوبسي.
خدنا بايوبسي. شفنا ايه كمان في الكولون؟ شفنا ايه في الكولون؟
شفنا hypertrophied colon.
لا يعني
أو
thickening of the wall, mural thickening. We don't call it enlarged. As enlarged colon is a dolicky colon. يعني you mean that the wall was thickened. فبيقولوا mural thickening suggestive of carcinoma. Yes. شفنا اسايتس قبل كده برضو. شفنا اسايتس لما شفنا الرابش سبين او يعني هيموبريتونيوم. وشفنا هيموثوركس. وشفنا the sign that we call air bronchogram. عارفه الاير بronchogram يا منى؟ طب tell me something about an air bronchogram. What is an air bronchogram؟
الالفيولاي بتكولابس وبيبقى البيتنت برونكس بتبقى هايبودنس.
وايه؟
ايه البرونكس او بتبقى بيتنت وبتبقى لونها هايبودنس بالنسبه لي.
تمام. طب what are the two types of collapse؟ What are the two types of collapse؟
obstructive.
ايوه.
وcompression من بره.
compression. Obstructive is also called absorptive because when the bronchus is obstructed, the air becomes absorbed. Which type of collapse is typical where you typically see an air bronchogram? تفتكر compression ولا absorption؟
compression.
تمام. وطبعا absorption an air bronchogram is also seen when the alveoli are. What also a typical cause of an air bronchogram when the alveoli, what can the alveoli fill with? They can fill with what?
Fluid.
They can fill with fluid, as in ايه يعني as in ايه؟ غير البلمونري edema. غير البلمونري edema بيبقى ايه؟ اعوذ بالله الفلويد اللي بيملى الالفيولاي يبقى الناس جالهم ايه يعني؟ اللي يبقى عندهم مليانه فلويد الالفيولاي مليانه اكسوديت يبقى عندهم ايه؟ يبقى عندهم ايه؟
نمونيا.
ايوه عندهم نمونيا. ايوه عندهم consolidation. A consolidated low will cause an air bronchogram because the alveoli fill with exudate and then the bronchi do not fill with exudate and the bronchi remain full of air. زي طب ولو تروما الالفيولاي يبقوا مليانين ايه؟ يبقى اسمها ايه في الحاله دي؟ ما اسمهاش نمونيا، يبقى اسمها ايه؟ زي ما الليفر يملى بلاد كده في التيشوز بتاعته، او زي ما الجلد يبقى تحته دم من غير ما يعمل هيماتوما، بيسموه ايه؟ ما هيماتوما لو في لمب، لكن لو ما فيش لمب يسموه ايه؟ لو ما فيش لمب زي ما الواحد يبقى عنده مثلا اتخبط في ايده وعنده ايكايموزز، ده اسم تاني الايكايموزز، ده اسم تاني ايه هو؟ what is the name for an ecchymosis? A bruise, okay, a bruise, but there's a third name. There's a third name. You know it. If someone sustains blunt trauma and there is interstitial bleeding, but without the formation of a hematoma, without the formation of a lump, بيقولوا a contusion. Contusions are very very important. You name them بقى من اول.
يعني اقول contusion في اللنج؟
من في البرين، في اللنج، في الميوكارديوم، في الليفر، في السبين، في الكدني، you name it. Contusions بالظبط. Interstitial bleeding from minor vessels that does not cause a lump is called a contusion. A lung contusion, the alveoli fill with exudate, but it's in this occasion it's blood. بلاش exudate, fill with fluid, that is blood. Okay, and then you call it a pulmonary contusion. A pulmonary contusion. And you talk about brain contusion, pulmonary, myocardial, يعني في كل حاجة, liver, spleen, all the solid organs. The muscle contusion, كلهم contusions. Interstitial bleeding, minor vessels, interstitial bleeding, no hematomas, اسمهم contusions. Okay. يبقى شفنا الحاجات دي كلها الحمد لله. شفنا الاير برونكوجرام. مين بيقول حاجة؟
Dr. M. Pradeep.
Okay, go on, Pradeep.
Doctor, in first row, I mean, I was confused initially, thinking as if it is a MRI, because if the pelvic bones I cannot see, I can see the rib cage, but I cannot see the pelvic bone. But in other second and third row, there is clearly the pelvic bones. I mean, hyperdense.
Because there is a gap where the pelvic bones are not seen. There's a gap in the body, the pelvic bones. You don't see the pelvic bones at one stage. You just see the lumbar vertebrae, but not the pelvic bones. But you can see the skin. You can see the skin that is hyperdense, and you can see all the fat that is hypodense. It's not only the bones. With an MRI, the fat appears high signal, but it doesn't appear like low signal. Fat will appear homogeneously low density, hypodense on all CT sequences. If this word applies, you don't talk about the CT sequence, you talk about an MRI sequence. But with all CTs, the fat will invariably appear hypodense. We can have another look. عايشة ممكن تحط لنا الفيلم تاني من فضلك؟ معلش. Which one are you talking about?
First row, I think this coronal cuts are in front. I mean,
you're talking about the coronal cuts. You're talking about the ones that we did not yet review. Okay. The ones that we did not review, Pradeep, or the ones that we already reviewed.
This one.
This one?
Yes, that's why I got.
It's because زي ما انت تقول كده, they're two. معلش يا عائشة متأسف. They're too anterior for the bones to be cut. They're too anterior. Okay, yes. This is the problem, but the bones then appear really white and dense, and that's it. You can note that and you can also note that the skin is hyperdense, but the subcutaneous fat is all not high signal. Okay.
Okay.
So it is an this is a CT and not an MRI. يلا يا Minna. علقي على Minna. Are you exhausted or do you want to continue? It's entirely up to you.
لا هكمل عادي.
هتكملي مكارة يا منى. مكارة. طيب okay.
Okay.
Minna is going to continue. We want to nominate a spokesman for next time inshallah. ويلا يا منى, go on. You'll be doing a great job. يلا قلنا what's happening with this woman ولا this man. The scale. Where's the scale? فين the corona sections? فين scale? ورينا scale كده فين? Where's the scale? اهو. Carlos was asking about the scale. The scale is beautifully depicted in this, depicted and shown on these diagrams. That the scale is beautifully depicted, no doubt about it. And obviously, you can measure things from craniocaudal on a coronal cut. Craniocaudal, you can measure them from side to side, but you can't on a coronal measure them from front to back, obviously. The contrast or non-contrast CT?
Contrast.
Contrast CT. يلا ورينا كده فين, where is the stomach? Show me the stomach and show me the liver.
The liver.
These images are going from anterior to posterior, yes. When you take a coronal image, you go from anterior to posterior. They're all reconstructed, but you go from anterior, you go from the very front, and then you reach the back. Yes, this is the liver. And where's the stomach? Where's the stomach? حتة صغيرة كده تحت الليفر اهي. حتة صغيرة تحت الليفر. فينها؟ Absolutely. And where's the gallbladder? Where's the gallbladder? Can you see the gallbladder?
دي الجولبلادر.
فين الجولبلادر؟ بالظبط. Where's the duodenum? Where's the duodenum? Can you see the duodenum also? Absolutely. Can you see the urinary bladder? فين urinary bladder? Is this a man or woman?
Or woman.
Why did you identify her as a woman and not a man? ايه الاورجن اللي عندها خلاكي تقولي انها identify the uterus? Point to the uterus. Absolutely. طبعا the kidneys are there. The source muscles. Where are the source muscles? The source. ما هي انوار. ما هو طبعا عبد الرحمن is not an easy person. He wanted to check the name in order to make a story out of it. فهي انوار. انا قلت حد هيطلع اسمها بقى وهيقول لك ده راجل ولا ده ازاي, and this whole story. يلا what's going on with this woman? What's going on with her? Yeah, the cuts where you've the very first cuts, the 3 rows or the very first cuts. You can see in the middle and in the lowest rows on your left hand side where you pointed to the uterus. What's going on? Compare it to the other side. ايه اللي حصل؟
compare ايه
شوفي كده. Develop a method to comment on the CT, the parites, the liver, the spleen, the urinary tract, the peritoneum. How about the parites? What's going on with the parites? Look at the parites. ايه اللي حصل للparites؟
في weakness أو يعني swelling.
Is it a simple weakness? Go on to the lower row. Look at the lower row.
لا, في swelling.
في swelling. And if swelling is a clinical term, you cannot call it a swelling. What is there?
Hernia.
في hernia, you can see the difference in the
فيها liver.
parites. فبالظبط كده. I was telling you to to note that the porites, there are the muscles on the left hand side, but on the right hand side the muscles are not there. There are no muscles. There's a very thin out muscle that you can see. شايفاها ولا مش شايفاها؟ شايفه thin out muscle؟ شايفه الجلد؟ point to the skin. Can you point to the skin? There's part of the skin that is shown, a very small part of the skin that is shown on both sides. She's absolutely. She may not be obese. It would be better to say she's got a normal or an abnormal BMI. She may have a lot of subcutaneous fat and may not be obese, and vice versa. Do not confuse two things: the amount of subcutaneous fat and the overall weight. They're two different things. People may have a lot of subcutaneous fat, and they may have a normal BMI, and vice versa. It's constitutional. They're two different things. You can all identify the subcutaneous fat as a hypodense area. You can all identify the skin. You can all identify the bones as really hyperdense areas. يلا فين الكيفا وفين الاورطه؟ خلينا في الفيلم انت معلمه عليه ده. يبقى this is the hernia. Which part is this hernia تفتكري؟ الهرنيا دي موجوده في انهي حته؟
lumbar.
برافو عليكي. برافو عليكي. This is a lumbar hernia. It may be an incisional one, maybe lumbar hernia is developed from the back, absolute back, and they develop the area of the lumbar triangle. The lumbar triangle مشهوره، وانت تقولي الباوند صفاتها لو انت فاكراها، بس وريني الاول الاورطه. فين الاورطه وفين الاورطه؟ ما شفتهاش لسه. انت بتعلمي نفس الفيلم اللي انت علمتي عليه سكين ولا على انهي فيلم؟
ايوه نفسه.
ايوه انا كنت ببص على فيلم تاني خالص. طب where is the IVC and where is the IVC؟
ده.
تمام. and where is the left renal vein؟ where is the left renal vein؟ the spleen, can you see part of the spleen؟
ده.
absolutely. Okay. You can also see the gallbladder. Can you see the gallbladder؟ انت علمتي على الجول بلادر قبل كده مش كده؟ ولا انا ما قلتلكيش؟
علمنا عليها.
خلاص. طب خلاص يبقى اوكي. سكانوجرامز، سكيلز، ويندوز، كونتراست، مش عارف ايه تاني في السي تي كنا بنقول عليه. طب يلا ممكن نشوف حاجه تانيه. You don't usually get a CT for a hernia, but this is really enlarged. The film that was really enlarged. Zoomed اهو. يلا اوكي. يلا كملي لنا بقى. هايل.
ده نفسه.
ده نفسه. يلا شوف لنا بقى ده الراجل ده ولا الست دي عندها ايه؟
هرنيا برضو.
هرنيا بس فين المرة دي؟
هنا بقى انجوين.
انجوينال. نازلة فين؟ نازلة فين فعلا؟
في السكروتم.
نازلة في السكروتم. تمام. مش عارف عندي انطباع ان فيها ايه كمان. بصي على يلا شوف لنا وير ذا بلادر في الفيلم to your left hand side. شوف الفيلم. يس. شوف لنا وير ذا بلادر and so forth. يلا. Now where is the head of the femur and where is the greater trochanter and where is the acetabulum and the symphysis and this sort of thing.
Okay, this is the head of femur in the acetabulum.
تمام. مكارة جدا. ايوه. يلا ورينا الفيمورال vessels. ورينا الفيمورال vessels. The femoral vessels are clearly seen in this image. where the femoral
Yeah.
vessels. ما شفتش لسه. انت علمتي على نفس الفيلم ولا؟
لا، على الشمال.
على الشمال.
مم.
مكارة ما عنديش اي افلام اتعلمتي على دول الفيمورال فاسلز تفتكري؟ لا شوفي راجعي نفسك تاني. ايه دول تفتكري؟ دول الفيمورال فاسلز كده. وعندك اي any other suggestions؟ ايه رايك دول ممكن يطلعوا ايه دول؟ يلا قولنا ايه دول ممكن يطلعوا ايه دول؟
ممكن بقى
قولي لنا دول يطلعوا ايه. فكري كده وقولي ممكن يطلعوا ايه الفيلم. بس بصي على الفيلم اللي تحت كده،
اللي تحتيه عشان في بايلاترال.
شوفي ايوه اهم شايفاهم the two femoral vessels which is the one that contains contrast. انهي اللي contain contrast؟
الارتري.
الارتري. او مش شرط هو اللي في الفيلم اللي هنا اللي contain contrast. is it lateral ولا medial؟ is it lateral ولا medial؟
lateral.
It's lateral. But this is the femoral artery. And how about the structure that lies medial to it?
الفيمورال vein.
الفيمورال vein that lacks contrast. And what is the area that is empty, just lateral, just medial to the vein? الاريا اللي لونها اسود دي شويه hypodense. What is this area?
الفيمورال canal.
The femoral canal, absolutely. The femoral canal, absolutely. It may be. نرجع بقى نقول what are the structures that you have seen, the two hyperdense structures that you have seen in this upper part, in this upper image. You have to be able to provide the differential diagnosis. It may be wrong, it may be right. انت رايك ايه؟ قول لنا كده ممكن تبقى ايه؟ انت قلتي femoral vessels. ايه تاني؟
بس هي unilateral.
ايه lateral؟ الفيمورال vessels باينين قدامك يعني ف they're not the femoral vessels. ايه تاني؟ what could it be؟ حاجه فيها صبغه. حد كان بيقول عظم. Do you think this is the bone؟
بس ليه في ناحية واحدة؟
عبد الرحمن بيقول ما هي ممكن تبقى
مش عارفة. I don't think it's bone.
You don't think it's bone. برافو عليك. Neither do I think it's bone. I can review the other image and I don't think it's bone. صح. فطب تبقى ايه تاني؟ ممكن تبقى ايه؟ عبد الرحمن قال حاجة برضو. ممكن تبقى ايه بقى؟
ممكن بقى تبقى كولون.
ايوه تبقى باول.
باول.
وانت how do you work it؟ ايه what about its density؟ طبعا its location is very very important. But because bowel can be present anywhere, you think about its density. What does it contain? Does it contain contrast? If it's a vessel or it's a bone, a vessel or bowel. هي كده فعلا. But you have to develop a method to analyze things. And by the time you don't need to analyze things, you just diagnose them offhand. Just like when you see an airplane, you don't need to analyze why is this an airplane and not a car anymore. You may have done that in the very early days, but no longer. يبقى زي ما انت شفتي كده دي inguinal hernia فعلا. بس بصي على البلادر كده، شوفي البلادر وشوفي
دي sliding hernia هنا خارجة.
يبقى you've got this impression like I've got. Yeah, I may be right, may be wrong, but I very much think that this is a sliding hernia. صح. There's a suspicion of sliding hernia. Why did you say so? وانت هايلة يا شهيرة. Why did you say so?
علشان البلادر خارجة مع في الهرنيا.
البلادر خارجة معاها. Why is the bladder got two colors like that? Why is the bladder why is the bladder two colors?
اليورين والكونتراست.
They're in the contrast, which is superior and which is inferior?
Contrast superior.
Is contrast is superior, and the thing is in the urine. Do you really think so? The contrast is superior? Contrast is superior. ايه رأيك؟
هو أنا مش شايفة الصورة دلوقتي.
أنت شايفة الصورة دلوقتي؟ ولا أنا؟
طب دكتور هو احنا
ينفع أسأل؟
طبعا.
اوكي، هو ايه اللي خلانا نقول انها انجوينال هيرنيا؟ يعني ايه اللاند مارك او ايه الابروتش اصلا اللي انا بدأت منه يعني؟
لقينا حاجه زي باول لوب قدام قدام الابدومن، قدامها لما نشوف الصوره تاني، فلقينا قلنا ان دي غالبا باول لوب نازله فين، هتبقى نازله في الهرنيا، هنشوفها تاني، بس يظهر عايش عندها problem. We'll see what we're going to do.
The doctor, that hernia was containing bowel loop.
It was containing a bowel loop. I think there was something that contained air.
But there was no contrast. I mean, it doesn't take contrast.
Contrast isn't constant because it depends upon the propagation of contrast in the peristalsis. If there's contrast, it's fair enough, but if it isn't contrast, you can never say that it is not a bowel loop. Then you depend upon the presence of air, and sometimes it contains only fluids. The thing is that if people drink contrast, they cannot uniformly opacify the bowel. You've got two factors. You've got the factor of gastric evacuation, and you've got the factor of bowel motility. If you want to fill the bowel quicker and at a more homogeneous way, you insert a tube, like we've been saying. Sometimes you call that a small bowel enema. Paradoxically, you call it a small bowel enema, where you introduce a tube through into the duodenum. You introduce it orally, or transnasally. I mean, just like an NG tube, but you locate it inside the duodenum, and then you overcome the problem of gastric evacuation. You tend to fill the bowel more homogeneously and at a quicker rate.
Okay.
اوكي، ما اعرفش بقى احنا هنقدر نكمل ولا ايه؟
معلش يا دكتور، بس اللابتوب فصل.
ما فيش مشكلة، ما فيش مشكلة خالص، ما فيش مشكلة. يعني Aisha, I thank you again for all the time you're dedicating for this business. I have to mention that very clearly, that dedicating loads of time when you're becoming ever so busy and ever so concerned by so many other things. I thank you in particular that you're dedicating all this time for helping us out of so many situations.
Thank you, Aisha. This is really great. Yeah.
Again, this is an area that is present in front of the pubic bone. This is the location of hernia. You can compare to the other side. It is not there. And you can see that the bladder is being pulled into the hernial sac probably. And I think that this contains a bit of fluid and air to my mind, okay? It may be momentum.
I mean, this is most probably a hernia. And why he's doing CT? I mean, it's that important.
I cannot answer you about this yet, Pradeep, but it's just, if you've got the image already, probably we have not requested it. Maybe they were doing it for any other reason. I'm not so sure. But if you've got it, then it's a chance to show, because CTs will not only, you may debate why did we do it. I don't know. I haven't got a clear answer for that. But if you've already got it, then you show it in order to consolidate theoretical knowledge, okay? At times we use CTs, but probably the CT was not indicated in this situation.
I mean, in real practice, it will be, I think, maybe malpractice, maybe, because they may suit us. This is, I think, just a hernia, then why to do CT?
ما عنديش إجابة واضحة يا براديب. I don't know. يعني in this country you can get images the way you want. There aren't very strict rules why you get and why you don't get an image, particularly if you're doing it in a non-academic area. بس أنا مش عارف. Okay. I don't know why did they get this CT done. I may have known and forgotten. ما أعرفش. That's at least it's a good chance to review hernias and sliding and this sort of thing. That's maybe if I get back to my notes and my whatever I've written on the images, I may remember why did we get it. Okay. بس طبعا you don't get a CT as a standard to operate upon the hernia unless it's an incisional one and you think there may be a recurrence, for example, following a section of any form of tumor.
تمام.
يلا هنكمل. How you want to investigate it for... Sorry, go on.
كنا بنقول اليورين والكونتراست.
يلا شوف لنا هنا where is urine, where is the contrast.
ده اليورين اللي هو فوق والكونتراست تحت، بس ده كده يعني posterior و anterior.
بالظبط. contrast is heavier, so the urine is almost always at a superior level and the urine is almost always at an inferior level. Okay.
بس مش هنا كده يعني ده posterior و anterior.
anterior posterior يعني قصدي superior inferior. متأسف أنا غلط.
لا أنا قصدي إن هو مش دي axial cut يبقى superior ويبقى posterior anterior.
تمام
صح؟
superior inferior صح لو أنت بتقولي كده. وanterior posterior يعني there is a bit of truth in both I think. لكن اللي فوق whatever lies at a higher level is the urine and whatever lies at the lower level is the
contrast.
Okay. Is the contrast because it's heavier. Okay. If we're standing, it's the reverse one. If it's standing, it's يعني lower and upper ولا يعني whatever بقى انت فاهمه انا عاوز اقول ايه. يلا نشوف اللي بعد كده. What are we going to see after that؟ أنا ايه بعد كده؟ bladder in the left groin hernia فعلا. We're talking about the same thing. يلا يا شريرة.
والسي تي بتاع نفس الشخص اللي
اوكي يلا ممكن تعلق لنا على الفيلم ده.
ده اكس راي.
دي اكس راي دي سي تي دي اكس راي. دي اكس راي خلاص. لا ده اكس راي طبعا. يلا what do you think about this X-ray? Which part of the body has been imaged?
Chest to abdomen.
The chest and the abdomen. Did they really X-ray the abdomen? Did they really X-ray the abdomen? يعني this question relates to did they X-ray the whole abdomen or did they X-ray part of the abdomen?
لا upper part.
Then this is an inadequate X-ray of the abdomen because if you want to X-ray one part of the body, then you have to X-ray it fully. Otherwise, your reporting will be inadequate. Report that the abdomen is normal, for example, when it's not, because just like exposures, just like when you're examining someone, did you expose them properly or not? If you haven't exposed them properly, then your clinical assessment will be inadequate. It's the same thing. طبعا the quality of this X-ray is not maybe because of the repeated يعني interim projections كده. لكن يلا قول لنا what does this CT show؟ قصدي film show, plain film show. Is it plain or contrast? Plain. Is it a man or woman؟ خلي بالك من عبد الرحمن هيبص لنا على الاسم بعد شويه. الاسم يقول لك ده راجل يا ست خلي بالك. فايه رايك؟
Woman.
Why do you think she's a woman?
Breast tissue, I think.
Breast tissue. I think there's a breast shadow. Yes, this is what I think. Remember that the men may have a bit of a breast shadow if they've got a gynecomastia that is fatty. That is fatty because gynecomastia has got two types: a fatty and a non-fatty one. الفاتي بتبقى because they've grown obese أو زي ما كان عبد الرحمن بيقول they've got a high BMI. Their breasts can also share in the same thing. At the times you've got actual breast tissue that forms a disc that is slender and very well-defined retroareolar زي ما انتم اكيد عارفين. لكن both types are called gynecomastia. Some people will restrict the term to the firm tender retroareolar disc, but sometimes people will not. يلا ايه بقى اللي باين؟
الستامك بابل.
الستامك بابل يعني انت شايف دي فعلا جاستريك اير بابل كده. We will not comment on the chest. The chest is half I don't know what. Let's just comment on this part of the abdomen that we can see.
ممكن تبقى باول.
يعني دي باول لوب، شايفه شكلها باول لوب، والراجل ده شكله متصور ايركت ولا سوباين ولا الست دي؟
ايركت.
Erect. Why did you say so? Why did you say that?
عشان
ما عنده شيء زي airflow
الفلويد
level اهو،
level.
مش عنده airflow level. طيب do you think that this lies within the confines of the abdomen? Does this lie within the confines of the abdomen, or is it a bulge or whatever you think? يعني في bulge في الكونتور of the abdomen ولا ما فيش bulge؟
ممكن في bulge.
طيب خلاص هي عائشة، هي السي تيز اللي جايه بتاعت الست دي برضو مش كده ولا بتاعت الراجل؟
يا دكتور.
اوكي. وحد بيقول اسايتس، ايه حكايه الاسايتس اللي بيسجست دي؟ why is عبد الرحمن suggesting there is ascites؟
الراديو اوباسيتي اللي موجوده مخبيه كل حاجه دي.
بالظبط. he thinks that there is a bit of an opacification of the abdomen that may suggest the presence of fluid inside the abdomen. It could be that, or it could be that the X-ray is I don't know, too soft. يلا هنريفيو بقى the CTs. Look at the CTs. Look at the CTs and expect what to find or what not to find. يلا هم شايفه الافلام بتاعتها، افلام I think they are very interesting images. يلا ايه رايك؟
هي يعني دي الكدنيز يعني.
فين الكدنيز؟ فين الكدنيز؟ انت مشاورة اني فيلم بس عشان ابقى معاكي. فين الكدنيز؟
هنا.
Yes, this is the kidney and this is the other one. Absolutely. Where's the spleen?
ده السبلين.
فين السبلين؟ انا مش شفت اهو. وطبعا the liver is on the other side. And we're do you think this is the very
الصوت بيقطع.
منى هو فين الليفر؟
ده
اللي هو فوق الكدني ده.
يلا معلش انا كنت لازم ارد بس معلش يا شريره فيلا. لا انت طيبه جدا على فكره. يلا do you think this is a posterior film or an anterior one?
Posterior. I think it's posterior. Doctor.
منى.
دكتور حضرتك سامعني؟ أنا مش سامعة.
الو منى.
أيوه.
مش عارف انا حصل لي حاجه بعد ما انا اتكلمت بقى اذا بستعمل ال الديفايس عاوز بقى ارجع استعمل التاني ده. مش الديفايس اعمل ايه يا جماعه عشان انا مش ده. طب يلا منى كملي. ايه اللي انت
السبيكر يعني
بره؟ ايه اللي علمت عليه ده؟
دكتور مشكلة في السبيكر. لو المشكلة في السبيكر فوق كده مكتوب جنب كلمة زوم في صورة سماعة، حضرتك دوست عليها بيفتح اللاود سبيكر.
طب يلا منى كده. يلا منى كده كويس خلاص شكرا. منى.
أيوه.
ده
ده
كده
شكله
هايل.
باول.
يلا كده خلاص. يلا يا منى ايه اللي بقى اللي بيحصل للست دي؟
ده شكله باول.
باول موجوده ليه؟ what did you say it's a bowel? this part that you
عشان
mark up
فيها air وفيها contrast
فيها contrast.
erogenous.
part of it was not full of contrast yet but then the most distant part is full of contrast. And where is it present? Where is it present?
in the femoral area. In
You think so? It's the femoral area? Do you think this is the
الانجوين.
Do you really think this is the
احنا at the back.
back. ده احنا رجعنا ورا خالص.
اوكي.
ورجعنا ورا خالص. يبقى what could it be؟ يعني ما احنا ده لو كان قدام بس ده very posterior. يبقى ايه؟ lumbar. absolutely. يبقى it could be another lumbar hernia. let's see. ممكن من فضلك يا عائشة تحط لنا the axial cuts مرة تانية. let's see the axial cuts. Can we identify on the axial cuts? يلا ايه رأيك؟ Is it identified on the axial cuts? See, in this situation, you need to look at all the cuts because one cut will not be sufficient. يلا screen them quickly. You're looking at one location. You're looking at the right or the left. Looking at the right or the left.
left.
left افتكري. The right or the left.
Right.
The right. The plain film has got its fallacies, but the CT will not have got its fallacies. طب يلا شفتيها؟ طب يلا ولا ما شفتيهاش؟ شفتي حته الباول دي اللي طالعه لبره؟ looking on the left side, anterior posterior.
لا ده anterior.
لا بس انت بتدوري على anterior posterior ولا حاجه anterior posterior؟
انا بدور على posterior.
طب وحاجه لونها ايه؟ هتدوري على حاجه لونها ايه؟
hyperdense او hypodense.
طب يلا يا هوا يا صبغه.
اهي ده hyperdense اهي.
بالظبط كده. شفتيها اهي. يبقى what type of hernia is this again؟
lumbar.
lumbar hernia again. طبعا lumbar hernia is nothing to worry about. You have to forget about them. You never encounter them. لكن اهو two unusual lumbar hernias that you've seen. I use CTs. طبعا you can almost always ask why did we get a CT? but the answer may not be so clear. But having done the CTs, whether we've requested them, at times you request CTs in order to keep a document. At times you request an investigation to keep a document. Some hospitals will have very strict code of requesting indications and contraindications to request certain investigations because they don't want to abuse things. On a private basis, things may be different because people may be on getting images irrespective of the indication. So it shouldn't be that. But having had the image, okay, we'll get the best advantage, make the best advantage of having it done and use it for educational point of view. خلاص يلا ممكن بقى نشوف حاجة أخيرة.
I used to stress on that point because seeing CT first I will exclude hernia because in first place I will not think of hernia. That's why I stress on that point.
You cannot do that because you may encounter hernia as a coincidence, and you have to comment on it. Okay, at times parietal masses are not so clear whether they're hernias or not. But you get, and you may want to know the contents. You may not be very happy to rely on your clinical. This may happen. وبعدين you'll be requested to comment on all the findings irrespective of their importance, because from a radiology point of view, you need to screen the image for all possible pathologies.
Yes.
Okay. You should not exclude hernias. If there's a hernia, it's a hernia. You may be getting an examination for something intra-abdominal, and you by chance encounter hernia. You shouldn't be omitting the description of it. Yallah, this will be our very last image for this morning. Woman has done a great job. We've reviewed a few para-aortic lymph nodes and we've reviewed a few hernias. Well, I think our pace is a bit slower than expected, but it's no problem. We did not get CTs done on the days during our live meetings. لكن ما فيش أي مشكلة. I don't think we've got any problems whatsoever. الحمد لله. يلا قولي لنا بقى يا منى ايه الأخبار هنا؟
في هنا bulge swelling على ال left side.
There's a region on the left side. The left or the right?
The left.
The left side. Which part of the abdomen? Which part of the abdomen? The upper or the lower?
Upper.
The upper? Do you really think so? Do you really think so? The upper?
لا lower. نكملها lower.
Lower كمان أكتر. How about it's occupying the vast majority of the side and the flank of the left side. Yes. What about its density?
Heterogeneous. Hypodense.
It's heterogeneous. Is it intra-abdominal? Is it intra-abdominal?
No. Extra-abdominal.
Extra-abdominal. It's parietal again, yes. It's heterogeneous, but يعني in the vast, is it, what density is it?
Hypodense.
Hypodense. Well, is it one single thing or is it lobulated?
هي heterogeneous. يعني single heterogeneous.
تمام.
ممكن نعمل.
طيب يلا ممكن نعمل زوم على واحدة اللي فيها اهو. اوكي يلا قادرة تقولي دي ايه طيب؟
ممكن تبقى lipoma.
ايوه lipoma برافو عليكي. Yes, it could well be a lipoma. Yes, this I would suggest this density of fat and a bit of hyperdensity is no problem. It's lobulated. Absolutely, it could well be that. Yes, but is it that? It could well be a large lipoma. So in order to say lipoma, you need to check the density of the fat. You have to be very clear about it. يلا طب ايوه فيها بينها septa. Yes. Yes, how about anything else? Alright, كده شوفي desmoid, maybe a desmoid. Yes, maybe a desmoid. هنشوف desmoids. يلا شوفي بس ايه اللي جرى هنا في يا ترى intra abdominal. شوفي الفيلم اللي احنا عاملين عليه اللي عايشه عاملين عليها زوم ولا عايشه مش عاملين انا اللي بكبر. شوفي الافلام اللي فيها الليفر فيري، الليفر كله. انهي افلام اللي انا عاوزك تشوفيها دي؟ الافلام اللي هي towards your right hand side towards the end. شوفي كده الباول اخبارها ايه بالنسبه لها.
الباول
شوفي الفيلم اللي هو last row. The last row. Look at the last row. لا the row بقى the row below that. ايوه the row below that بالماوس اهو. انزلي row. ايوه this one. Yes this one. شوفي الباول داخله فيها ولا مش داخله فيها. ايوه this one absolutely. الباول داخله فيها او بتحاول تدخل فيها من ايه؟
يبقى في weakness، يبقى هنا بتحاول تدخل
اهي حته منها داخله. الديزمويد is more anterior. yes definitely.
يبقى ممكن تبقى هرنيا، ممكن تبقى
أي نوع من الهرنيا صح؟
ودي فيها يعني ما فيهاش باول، لسه ما دخلش الباول.
اللي يبقى جواها طب لما تكون لايبوما. برافو عليك، يبقى جواها اومنتم. برافو عليك، مكاره جدا، انت مكاره جدا جدا كالعاده. يعني انت مكاره شديده المكر، وهو في ديفكت في الابدومين وول مكان ما انت مشاوره. Where is the rectus muscle? Show me the rectus muscle. Where the two recti? تمام. lateral to the border of the rectus. Then this is probably what type of hernia اللي تطلع من lateral border of the rectus ده؟ اللمبر من rectal border of the rectus؟ لا انت كده ما عرفتيش تجيبي. lateral. انت اللمبر كانت راجعه لورا خالص، دي راجعه لورا بس مديه من قدام، فتبقى ايه؟
شباجيليان.
تمام. شكرا يا منى. You were great today. It's exactly 9 o'clock. It's the end of our session this morning. I thank you all. I thank Aisha in particular. I thank Muhammad طبعا again. I hope to see you بقى on Saturday إن شاء الله. And discuss the timing whether you want to start at 9. I don't mind. بس I'll be speaking to you بقى over the weekend إن شاء الله. إن شاء الله. متشكر جدا يا عائشة.
شكرا يا دكتور.
وشكرا يا منى. Thank you all. I'll see you very soon again إن شاء الله. عائشة متشكر قوي قوي قوي. شكرا يا عائشة.
العفو.
اوكي. شكرا يا محمد. شكرا يا منى.
شكرا يا دكتور.
عفوا يا دكتور، مع الف سلامة.
سلام يا نهال.
سلام يا دكتور. باي باي.
باي باي.